You are live, sir.
Thank you very much. Thank you very much, Jay. So, very good evening and a warm welcome to all in the audience for today's wonderful session. And the session is on the platform which is called as Ruma Digi Conclave. I welcome you all on behalf of Zydus Synovia. This program is been an educational grant by Zydus Synovia. So I welcome every one of you in the today's session by Dr. Bodhisattva Chaudhary. Uh, Today's session is really very important and it is going to be very much in detail about seronegative arthritis. So this is today's topic. Going into the detail of Dr. Bodhisattva Chaudhary, sir is a head of department, emergency and critical care department, consultant physician and rheumatologist at ILS Hospital, Havra. So today I welcome Dr. Bodhisattva Chaudhary for this wonderful session. Thank you very much, sir, for taking your precious time out today for this session and giving us your time so that everybody in the audience will be benefited. So welcome, sir, and session over to you, sir.
Thank you, Vishal, for the invitation. Let me just share my slides.
Yeah. You can share, sir.
Okay, can everyone see the slides?
Yes, sir. Slide is visible and your voice is also very clear.
Okay, so today's topic is seronegative arthritis. Now, the reason I picked up this arthritis because it's been difficult to diagnose seronegative arthritis. It's completely easier when it becomes seropositive because you do some markers like RA factor, anti-CCP or ANA, you get that positive, then you go to a specific direction and you can diagnose the disease. But seronegative arthritis, everything comes out to be negative and you don't know what to do with the patient. You want to give any anti-inflammatory or you want to give any painkillers. So it becomes very difficult. So today we are going to talk about what to do when you see this kind of patients, what diagnosis you can think about, and how to manage these cases. Now, if you see the classification of arthritis, if arthritis can be inflammatory or non-inflammatory, it may be seropositive, seronegative, infection, or crystal-induced. Now, seropositive arthritis, commonly we all know rheumatoid arthritis, lupus, scleroderma, vasculitis, Sjogren's, or the other seropositive diseases. In seronegative arthritis, we have the Spondyloarthropathies like Ankylosing Spondylitis, Psoriatic Arthritis, Reactive Arthritis, IBD-Associated Arthritis. Infection arthritis is because of any infection in the joint, and crystal-induced arthritis are gout and pseudogout. Now, by definition, seronegative arthritis means the arthritis which is negative for rheumatoid factor or any other autoantibody like anti-nuclear factor or anti-CCP antibody or any other serological abnormalities. The commonest group of disease that comes within the seronegative arthritis are called Spondyloarthropathies. They are a group of inflammatory arthropathies that share the distinctive clinical, radiographic, and genetic features. They include Ankylosing Spondylitis, Reactive Arthritis, Psoriatic Arthritis, and Enteropathic Arthritis. You can see the picture. Apart from them, the others are juvenile spondyloarthropathy, which is seen in the young patients, and undifferentiated spondyloarthropathy, which is a group of spondyloarthropathy which is not any of the other. Common features is all of them. They are seronegative, which means the rheumatoid factor is absent. Rheumatoid nodules are absent. Frequent association with HLA-B27. A tendency to occur in the same family, which is say genetic predisposition or familial aggregation. Inflammatory axial arthritis, mostly presenting with sacroiliitis and spondylitis. Oligoarthritis can happen generally with asymmetric presentation. Patient may have a pain swelling of right knee, but left knee might be absolutely normal. Enthesitis, inflammation of the enthesis, the size where the tendons and ligaments inside to the bone, like plantar fasciitis, Achilles tendonitis, and costochondritis. Among which Achilles tendonitis and costochondritis are extremely common in spondyloarthropathy. And extra-articular features, involvement of patient other fun joints like eye, which can cause anterior uveitis, skin causing rash, GT urinary tract. So if you come to association with HLA-B27, ankylosing spondylitis, you can see more than 90% of patients HLA-B27 positive. Ritter syndrome or reactive arthritis, that is more than 80%. IBD-Associated Arthritis around 75%, and Psoriatic Arthritis around 50%. So let's come to the commonest of them all, Ankylosing Spondylitis. It's a chronic inflammatory disorder of unknown cause that primarily affects the axial skeleton, peripheral joints, and extra-articular structures. More than 90% patients are HLA-B20 positive, more common in men at 3:1 proportion. Age of onset typically between 20 to 40. More commonly involves the axial skeleton, although peripheral joint may also be affected, most commonly knee, ankle, and shoulder. Pathology, sacroiliitis at the earliest manifestation of AS, but you may have patients whose first presentation might be knee pain and swelling. So sacroiliitis is most commonly the earliest manifestation, but there might be exceptions. Synovitis, pannus, myxoid marrow, subchondral granulation tissue, and marrow edema can be found. In spine, there is inflammatory granulation tissue at the junction of alveolar fibrosis and vertebral bone. The outer alveolar fibers are eroded and replaced by bone, forming syndesmophyte. So if you can see the difference of a joint, if you can see the bone response between rheumatoid arthritis and spondyloarthropathy. Rheumatoid arthritis, there is actually joint destruction with osteoclast formation, whereas in spondyloarthropathy, there is osteoblast activation and new bone formation as in the form of syndesmophyte. Pathogenesis of AS is thought to be immune-mediated, but there is no direct evidence of any kind of autoimmunity. There is also uncertainty regarding the primary site of disease initiation. A lot of research is still going on. The common feature that you can get is squaring of the vertebral bodies. One of the earliest radiographic signs of enthesitis is caused by erosions of the superior and inferior margins of vertebral bodies, resulting in loss of normal concave contour of the anterior surface. We can progressively go to bamboo spine. There is the typical diagnostic feature of ankylosing spondylitis. Thin and slender syndesmophytes are generally evident, representing ossification of the outer layer of alveolar fibrosis. On AP lumbar spine radiograph, the syndesmophytes thicken, become continuous, giving knobbly appearance. As you can see in the picture, what happens in healthy spine and what happens in ankylosing spondylitis spine, there is inflammation of the joints, the disc, and then fusion causing a bamboo spine. In a picture, you can see again, the stage 4, there are fusion causing a bamboo spine-like feature. Clinical manifestations, the symptoms of the disease are usually first noticed in late adolescence or early adulthood, median age being 23. The youngest I have seen is the case of a child of 13 years. The initial presentation of AS generally occurs in the sacroiliac joint. Involvement of sacroiliac joint is required to establish the diagnosis. This is very important. Sacroiliac joint involvement is followed by involvement of the discovertebral, apophyseal, costovertebral, and costotransverse joints. Initial symptom is usually dull aching pain. Incidence in onset felt deep in the lower lumbar or gluteal region, accompanied by a low back morning stiffness of up to few hours duration that improves with activity and returns following inactivity. This is a very important point in these group of spondyloarthropathies. In these cases, pain actually subsides on activity while it returns following inactivity. Whereas if you can see the other common arthritis like rheumatoid arthritis, osteoarthritis, pain always increases with activity. Arthritis in the hips and shoulders occurs in 25 to 35% of patients. Arthritis of peripheral joints other than the hips and shoulders, usually asymmetric, occurs in another 30% of patients. Stoop toward position, this is the normal posture of the patient. In advanced ankylosing spondylitis patient the entire spine gets fused, the neck gets fused, and patient becomes a stooped appearance. This is one more thing that there are a lot of time. A patient with advanced stage, if come walking to your chamber, you can actually diagnose the case by seeing the patient walking towards you, with this typical stooped over posture. Neck pain and stiffness from the involvement of the cervical spine are late manifestations. Chest expansion is commonly measured in ankylosing spondylitis to monitor the progression of the disease. It is measured as the difference between the maximum inspiration and maximal forced expiration in the fourth intercostal space. Normal chest expansion is more than equal to 5 centimeter. Anything less than that is significant. Also, one more test you can do to monitor the progression of disease is Schauber's test, which monitors the restriction of lumbar movement. You mark the patient's back at the level of posterior suprailiac spine, place one finger below this mark and second finger at 10 centimeter above this mark. And then patient is instructed to bend forward and touch his toes. If the distance between the finger increases less than 5 centimeter, that means lumbar flexion is limited. You can do this test in every follow-up visit to understand the progression of the disease, how much the disease is progressing. Peripheral musculoskeletal involvement occurs in almost 30 to 50% of patients. The commonest areas involvement are Achilles tendon, polyacrylic tendinitis, plantar fasciitis, at the tibial tuberosity, superior inferior pulse of patella, and iliac crests. Now let's come to the extra-articular manifestation, which are also quite common. uveitis is the commonest extra-articular manifestation of AS, occurring in almost 30% of patients. It can also present with iritis or iridocyclitis. Usually acute, unilateral, and non-granulomatous. Patients will complain of acute eye pain, increased lacrimation, photophobia, and blood vision. A lot of time we get patients initially go to ophthalmologists with complaint of eye pain. They ignore the low back pains. When they go to the eye specialist, they refer the case to rheumatologist suspecting a case of AS. The other involvement can be cardiovascular disease, aortitis of the ascending aorta resulting in aortic valve insufficiency, mitral valve insufficiency, and atrioventricular block, which can actually be life-threatening. Pulmonary disease, restricted lung disease is extremely common with bilateral apical pulmonary fibrosis. Renal disease, amyloidosis is a very, very rare complication of AS in patients with severe active long-standing disease. I have not seen such case in my life so far, but there have been cases reported. GI disease, asymptomatic inflammation of the proximal colon and terminal ileum has been observed and is actually quite common. Laboratory findings. There is no laboratory test which is diagnostic of AS. HLA-B27 can be found in 90% of patients, but you have to remember HLA-B27 may be positive in a lot of patients who does not have AS or any other spondyloarthropathy. So just positivity of HLA-B27 cannot be taken as a diagnostic point for axial spondyloarthropathy. The significant point one is ESR and CRP are elevated. Patient may have mild anemia, which is most likely anemia of chronic disease. Patient with severe disease may show an elevated alkaline phosphatase level. Elevated serum IgA levels are also quite common. And most significantly, all the other seromarkers like RA factor, anti-CCP, and anti-nuclear antibody are absent. Radiographic findings, the earliest signs can be detected by 3 to 6 months after the onset. Generally, the earliest finding are the sacroiliac joints. Early patchy osteoporosis develop around the distal third of both the bones. Joint margins become ill-defined and joint invertebrates become whitened. Subcorner erosion start when multiple they produce a rosary effect. This is the typical picture of acute sacroiliitis. But let me tell you, it is very difficult to diagnose AS on the basis of only X-rays, excepting in advanced cases. In early cases, X-ray changes are very subtle. In a lot of time, it may be missed. So if you have any clinical suspicion of patient complaining pain, tenderness, and pain in sacroiliac joint, and you see the patient with HLA-B27 is positive, or you are suspecting case of ankylosing spondylitis, if the X-ray is inconclusive, go for a CT, and the best is MRI of sacroiliac joint. It can give you the best idea. Lumbar spine, the earliest change is squaring of the anterior portion of the vertebral bodies. The anterior concavity of the body is slowly lost. It is found initially at the upper lumbar and lower thoracic regions, and there will be loss of lumbar lordosis. As you can see in the second picture, there is a fusion of the symptoms giving a bamboo spine-like picture. Paravertebral ossification develops beneath the anterior longitudinal ligaments within the annulus at each level. The ossification develops vertically in contrast to those developed in osteoarthritis. Finally, the appearance is bamboo spine. In cervical spine, extreme bony bridging extends along the anterior aspect of the vertebral bodies. There will be loss of lordosis and apophyseal joints become ankylosed. Hips, severe osteoporosis occurs in both sides of the joints. erosions develop and the joint space become reduced. If you go for the diagnostic criteria, which is the ACES classification criteria most commonly used, they are the main criteria to in patients in back pain considering more than 3 months and age of onset less than 45 years. Patient must have sacroiliitis MEG plus more than one spondyloarthritis feature like inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease or ulcerative colitis, good response to NSAIDs, family history of spondyloarthropathy, HLA-B27, elevated CRP. Or patient may have HLA-B27 positive plus any two of the spondyloarthropathy feature. Okay. In sacroiliitis means a definitely radiographic sacroiliitis X-ray or active inflammation on MRI, which is highly suggestive of sacroiliitis. To qualify the criteria, as I was saying, the inflammatory back pain axial spondylitis it must be chronic, more than 3 months onset. Back pain should have 4 or more of the following characteristic features: age of onset below 45 years, insidious onset, improvement with exercise, no improvement with rest, and pain at night with improvement upon getting up. Treatment: general measures are patients are encouraged to remain active and follow their normal pursuits as far as possible. They should be taught to maintain satisfactory posture and to perform spinal exercises every day. Swimming, dancing, and gymnastics are ideal form of recreation. Swimming, I would insist, is the best exercises in patients with ankylosing spondylitis. There are a lot of patients who actually stay pain-free and medication-free by doing regular swimming. Rest and immobilization are contraindicated because they tend to increase the general feeling of stiffness. NSAIDs, they improve the spinal pain, peripheral joint pain, and function over a short period of time. They don't prevent or retard the progress to ankylosis. They only relieve a symptomatic relief. Next comes the TNF inhibitors. Etanercept, infliximab, adalimumab, golimumab, and satralizumab pegol has all been approved by US FDA as therapies for AS, initiated after NSAID therapy has failed. Infliximab, we can give an infusion of 5 mg per kg body weight IV at 0, 2, and 6 weeks, then every 6 weeks. Etanercept, 50 mg subcut once weekly. And then adalimumab, 40 mg subcut every alternate weeks. One more significant development is in the use of IL-17 inhibitors, which is secukinumab. It slowly became one of the primary choice of therapy due to the less chance of TB deactivation from other biologics and actual chance of radiological improvement. It is the only drug so far which has been shown to cause some kind of radiological improvement in the patient. Dose in AS is 150 mg subcutaneous weekly for 5 weeks, then once a month. DMARDs we actually use still a lot of times, but the evidence says they don't help a lot. The DMARD that is commonly used is methotrexate. Methotrexate has been shown to benefit in some cases of peripheral arthritis, but in axial arthritis, it does not cause much of help. And sulfasalazine, although it has been used for years in ankylosing spondylitis or other spondyloarthropathies, all the recent studies show that it does not help the patient, and its use is being slowly coming down in case of ASS. Joint replacement: patient with significant involvement of the hips may benefit from THR. Heterotopic bone formation may occur even after total joint replacement, especially around the hip. Heterotopic bone formation can be reduced by giving the patient NSAIDs or employing radiation therapy postoperatively. Common exercises that are needed like leg raise, arm raise, side plank, gluteal stretch, extension exercise, and tilts and curls. Next comes to reactive arthritis. It refers to acute non-purulent arthritis complicated by infection elsewhere in the body. Syndrome was first discovered by Hans Ritter in 1916 and known as Ritter's disease as well. A clinical triad of urethritis, arthritis, and conjunctivitis occurring some weeks after any dysentery or genital infection. But the common classical triad is found is only less than 1/3 of cases. Etiology: the commonest etiology cases you can see is gastrointestinal pathogen like Shigella, Flexneria sonnei, Salmonella, Campylobacter, and Yersinia enterocolitica. Lymphocanal venereum and chlamydia trachomatis have been implicated as sexually transmitted infection causes. Post-venereal onset more common in sex in male, almost 5:1, but in eccentric cases, almost equal in 1:1. Course is generally self-limiting, less than 6 months, chronic, but it may turn chronic and intermittent. Pathology, the pathological changes are essentially the same as ankylosing, with the emphasis on large joint arthritis and chronic disease course tending towards sacroiliitis and spondylitis. Synovial histology is similar to that of other spondyloarthropathy. Enthesitis shows increased vascularity. There may be macrophage infiltration of fibrocartilage. Histopathology evidence of inflammation has been occasionally noted in colon and ileum. Clinical features, if you can see, the most common age of group 18 to 40 can occur in children over 5 years of age. In older adults, men are affected more than the women, and the ratio is about 10:1. The common organ involvement, apart from arthritis, you can see conjunctivitis, uveitis, mouth ulcers. In heart, again, aortitis, pericarditis, spondylitis, sacroiliitis, urethritis, and fasciitis. The acute phase of disease is marked by an asymmetric involuntary arthritis of the lower limb joints. Knee, ankle, subtalar, metatarsopharyngeal, and two interference joints are most commonly involved, but the wrist and fingers can be involved as well. Dactylitis or sausage disease, a diffuse swelling of the solitary finger or toe, is a distinctive feature of reactive arthritis. Tendinoathletis tendinitis and plantar fasciitis is also quite common. As you can see, this is the typical picture of dactylitis of the fingers. Sometimes they are actually diagnostic for cases of reactive arthritis or psoriatic arthritis. Other feature can happen in men: mild dysuria, mucopurulent urethral discharge may present at prostatitis or epididymitis. In women, dysuria and purulent vaginitis or cervicitis with vaginal discharge. Ocular disease is common, ranging from asymptomatic conjunctivitis to an aggressive anterior uveitis. And the skin lesions, is keratoderma, papillosarcoma skin rash comprises vesicles that become hyperkeratotic, forming crust before disappearing, but they are very rare. They are not commonly seen. The chronic phase is more characteristic of a typical spondyloarthropathy with feature resembling those of ankylosing spondylitis. Because the enthesitis in reactive arthritis, you can see there is more inflammation, more redness because of increased vascularity. One more thing I'd like to point out, recently we are seeing a lot of cases of reactive arthritis in post-COVID patients. Now, in post-COVID patients, the pictures are not exactly typical. The involvement of genital is not that common, but the most common feature that we are getting is typical of seronegative arthritis, onset 2 to 3 weeks after COVID initiation. Patients are presenting with polyarthritis with more involvement of exoskeleton and eye involvement. Laboratory findings: the test for HLA-B20 is positive in 75% cases of patients with sacroiliitis. ESR may be high along with CRP in active phase of disease. Radiographic findings, you can see in earlier mild disease, radiographic changes may confine to extra-articular osteoporosis. With long-standing persistent disease, margin erosions and loss of joint pain can be seen in affected joints. Sacroiliitis spondylitis may be seen in late sequelae. Sacroiliitis is more commonly asymmetric than in AS and spondylitis and can begin anywhere along the lumbar spine. The syndesmophysis may be asymmetric, coarse, and non-marginal. Treatment: most patients are able to benefit from some degree of high-dose NSAIDs. Indomethates is most commonly used in a dose of 75 to 150 milligram per day in divided doses, but other NSAIDs can also be tried. Majority of the patients with chronic reactive arthritis due to chlamydia, there is a 6-month course of rifampicin plus erythromycin or rifampicin plus doxy. Tendinitis and other enthesitic lesions may benefit from interlesional corticoids. Topical steroids may be used for uveitis. TNF inhibitors like infliximab may be used in refractory cases. Next, psoriatic arthritis. Psoriatic arthritis refers to an inflammatory arthritis that is characteristically occurs in individuals with psoriasis. 60% of those with psoriatic spondylitis or sacroiliitis have HLA-B20 positivity. The common areas of psoriatic lesions: scalp, ears, elbows. On the most common are the extensor surfaces: elbows, fingernails, toenails, knees, also around umbilicus and around genitalia and gluteal cleft. Pathology, the inflamed synovial of psoriatic arthritis resembles that of RA, although with somewhat less hyperplasia and similarity than in RA and with greater vascularity. Unlike RA, psoriatic arthritis shows prominent enthesitis with histology similar to that of other spondyloarthritis. That's right, they are kept with in the group of spondyloarthropathy. Clinical feature, in 60 to 70% cases, the psoriasis precedes joint disease, but in 50 to 20% cases, the two manifestations may appear within 1 year of each other. In 15 to 20% cases, the arthritis precedes the onset of psoriasis, which is actually secondary psoriasis. These cases, the diagnosis becomes a bit tricky because if the patient comes to you with a known case of psoriasis and the typical features, it becomes very easy to diagnose case of psoriatic arthritis. But let's say a patient comes to you who has not developed any psoriatic disease, but you can see the joint pains are typical of ankylosing spondylitis, no history of recent infection, and the patient has a typical sausage disease or dactylitis. Always keep psoriatic arthritis in mind and also ask for the history if anyone in family has psoriasis. If any one of the parents has psoriasis and the child, the younger male or female present to you with the same features of axial spondyloarthropathy, there is a possibility it might be a case of psoriatic arthritis. Joints commonly affected, you can see neck, shoulder, elbows, base of spine, like spondylitis and on sacroiliitis, wrists, all joints, including knuckles, fingers, thumbs, knees, ankles, all joints of toes. So basically, major, all small and large joints. The key features that help in distinguishing between psoriatic arthritis and ankylosing. Psoriatic arthritis, nearest female is 1:1 and ankylosing is 9:1. The sacroiliac joint and axis involvement is 100% ankylosing, where it's only 35% psoriatic. Spinal movement depression is comparatively less in psoriatic. Peripheral joint involvement is far more common in psoriatic arthritis. Peripheral joint pattern, upper and lower limbs with larger small joints, but in ankylosing it's mostly lower limbs with large joints. Dactylitis very common in psoriatic. HLA-B20 positivity more common in ankylosing. And spinal radiology, in psoriatic arthritis, there is random distribution with asymmetric chunky syndesmophytes, whereas ankylosing it is contiguous involvement with symmetric and classical syndesmophytes. The spectrum of arthritis associated with psoriasis is broad. 5 patterns can be described like arthritis of DIP joints, asymmetric oligoarthritis, symmetric polyarthritis similar to RA, axial involvement, spine and sacroiliac, and finally arthritis mutilans and highly destructive form of disease. So it is a bit difficult to diagnose the disease unless the patient has a case of psoriasis, because it can involve any joint in any combination, whatever. Nail change. This in lot of patients, when the patient does not have typical psoriatic rashes, nail changes can be a point of diagnosis. The pitting of fingers or toes occurs in almost 90% patients of psoriatic arthritis. There may be widespread shortening of the disease, which is called telescoping. Eye involvement and either conjunctivitis or uveitis is reported in around 7 to 33% of psoriatic arthritis. Nail changes, 6 types of nail changes commonly seen: pitting, horizontal ridging, onycholysis, various discoloration of nail margins, dystrophic hyperkeratosis, and combinations. 6 types of nail pattern, as you can see, the nail pitting, the commonest one, onycholysis, subangular hyperkeratosis, oligoarthritis involving the fingers, distal arthritis, where you can see the joint involvement mostly distal, and lastly, it can cause joint deformity similar to osteoarthritis. The most severe form of psoriatic arthritis is arthritis mutilans, where almost all the joints are severe, joints of hand are severely destroyed, causing a deformity. Laboratory findings: ESRCRP elevated. About 10% of patients may have anti-CCP antibodies. Uric acid may be elevated in the presence of extensive psoriasis. HLA-B27 found 50 to 70% of patients with axial disease, but 20% of patients with only peripheral joint involvement. So there you might get patients with typical arthritis with anti-CCP antibody positive and HLA-B27 positive. I have seen patients like this. Initially, I thought the case to be rheumatoid arthritis, but over time, when the patient started developing rashes, it became evident the patient actually has psoriatic arthritis. And the treatment of rheumatoid and psoriatic differ slightly. Radiographic findings, characteristics of peripheral spondyloarthritis include DRP involvement, including classical the pain in cup deformity, pencil in cup deformity, but it's not very common. Marginal proliferative erosion, small joint ankylosis, osteolysis of phalanges and metacarpal bones with telescoping of diseases, which is causing the shortening of fingers, and periosteoitis and proliferative new bone at the sites of enthesitis. Characteristics of axial psoriatic arthritis include asymmetric sacroiliitis compared with the idiopathic case, less superficial joint arthritis, fewer and less symmetrical and coarse syndosophites. As you can see in the X-ray, all the syndosophites development are asymmetrical. It is seen in one side of the spine, but not the both sides. Whereas in ankylosing, you can see in the X-rays, it is always in both sides. So the classification criteria of psoriatic arthritis, evidence of current psoriasis, a personal history of psoriasis, or a family history of psoriasis. Typical psoriatic nail dystrophy, negative test for RA, dactylitis, which is one very common feature. It may have a patient may present with a current dactylitis or a history of dactylitis. And lastly, radiographic evidence of juxta-articular new bone formation on plain radiographs of hand or feet. Treatment in mild disease, no more than topical preparations to control skin disease, and NSAIDs for arthritis are needed. A resistant form of arthritis, immunosuppressive agents like methotrexate and TNF inhibitors like infliximab, etanercept, adalimumab, and seroconazole has been effective. The common DMARDs used are methotrexate, sulfasalazine, leflunomide, and cyclosporine. Steroids in pulse doses, both oral and IV, can be used to control the initial inflammation and symptoms, along with dermatology consultation. Next comes enteropathic arthritis. Both forms of IBD, which is ulcerative colitis and Crohn's disease, are associated with spondyloarthropathy. Two types of involvement, mostly peripheral or sacroiliitis, spondylitis, both can be seen. Peripheral arthritis occurs about 15% of patients with inflammatory bowel disease. Typically, larger joints are involved in asymmetric fashion. Synovitis and joint erosion can occur. Men and women are affected with equal frequency, and there is no particular association with HLA-B27. Sacroiliitis spondylitis, this pattern is seen in about 10% patient with inflammatory bowel disease. HLA-B27 positive in almost 60% of cases. There is an increased incidence of ankylosing spondylitis in close relatives. Unlike the peripheral arthritis, sacroiliitis shows no temporal relationship to gastrointestinal inflammation, and its course is unaffected by a treatment of bowel disease. An extra-intestinal manifestation, uveitis, pyodermal aneurysm, which is a non-healing ulcer in external surface of a leg, erythema nodosum, and clubbing of fingers. Laboratory findings on patients with AS and IBD, 30 to 70% can carry the HLA-B27 gene. Apart from that, in inflammatory parameters like CRP and ASR can be elevated, hemoglobin may be low due to anemia chronic disease, or in case of persistent blood loss and iron deficiency due to IBD. Radiographic findings, the changes in exoskeleton are same as uncomplicated AS. Treatment, infliximab and adalimumab are effective in induction and maintenance of clinical remission in both Crohn's and ulcerative colitis. Treatment of IBD, including sulfasalazine-related drugs like mesalamine, systemic glucocorticoids, and glucocorticoid enema sometimes, and other immunosuppressive drugs as mentioned are also usually of benefit for associated peripheral arthritis. Lastly, undifferentiated and juvenile onset spondyloarthritis. Patients who do not meet the classification criteria are included in this. Approximately one half of the patients with undifferentiated spondyloarthropathy are HLA-B27 positive. In familial cases, which are much more frequently B27 positive, there is often eventual progression to classical AS. Juvenile onset spondyloarthropathy begins between the ages 7 and 16, most commonly in boys 60 to 80%, and asymmetric, predominantly lower extremity of oligoarthritis and enthesitis occurs. Extra-articular features are generally absent. Prevalence of HLA-B27 in this condition is approximately 80%. Many of these patients go on to develop AS in late adolescence or adulthood. Management of undifferentiated spondyloarthropathy is similar to that of other spondyloarthritis. So to summarize whatever we spoke of today, seronegative arthritis is a group of inflammatory arthropathies that share distinctive clinical and radiographic and genetic features, negative for RF or other autoantibodies, frequent association with HLA-B27, inflammatory axial arthritis, generally sacroiliitis and spondylitis, enthesitis, extra-articular manifestations, eye, skin, and generative tract, they are commonly seen. Includes ankylosing spondylitis, psoriatic arthritis, reactive arthritis, intraopathic arthritis, juvenile spondyloarthropathy, and undifferentiated spondyloarthropathy. Diagnosis is mostly clinical, followed by radiographic, which is X-ray or CT, MRI, lab parameters like ASD, ESR, and CRP. Regular exercise, swimming, dancing, gymnastics will help. Treatment, NSAIDs, DMARDs, biologics, mostly TNF alpha inhibitors and interleukin-17 inhibitors. Conclude. Thank you.
Thank you very much, sir. Thank you very much for your wonderful session on seronegative arthritis. And I'm sure that everybody in the audience have enjoyed the session today and got enlightened with so much of knowledge about seronegative arthritis, which has been told us today by a consultant rheumatologist, which is a super specialty, as everybody is aware about. So thank you very much, sir, first of all, for taking your precious time today out for us. And thank you everyone in the audience as well. So there is one question which has been asked from the audience, and everyone, you are welcome to ask questions so that we will answer your question. I will just read out, sir, that question for you. Somebody is asking the role of Igratimod. Might have seen the not the part of presentation, but might have seen the brand name in the invitation card. So Dr. Alok Kumar is asking, what is the role of Igratimod?
Igratimod, so far, there is no evidence of role of Igratimod in any case of seronegative arthritis or any spondyloarthropathy. Igratimod is indicated only in case of mild to moderate rheumatoid arthritis in conjunction with methotrexate.
Right.
Apart from rheumatoid arthritis, it has not been studied extensively. It's a new molecule, mostly a Japanese molecule. More studies are needed, so it may happen in future and see.
Right, sir. Thank you very much, sir. This is the question which has been asked from the audience, and I'm sure that everybody in the audience have get enlightened with the knowledge which has been shared by Dr. Bodhisattva Chaudhary with us today through seronegative arthritis topic. So with this, sir, shall we close the topic so that yeah. So
okay.
And the last word, sir, thank you very much once again for taking your time today for us.
Thank you for giving me the opportunity.
Thanks a lot, sir. And we will definitely meet you soon on another platform with another interesting topic. And I'm sure that you will be able to share with us. So thank you everyone in the audience, and thanks a lot for your presence today. And yes, good night and have a good Sunday.
Thank you. Same to you.